Thank you, India Valve, for inviting us so that we can show a case from here. And myself, Dr. Annapurna Kini, Director of the Cath Lab and Structural Program here. And we have Gilbert Tang, who is the Director from the surgical side. We have Bhavandar Penta, who is our new faculty who has joined, fully trained Mount Sinai. Then he stayed here. Lucy Safi will be on the echo. And we have two fellows, Pratish and Krishna, who are structural fellows who are going to be part of this. And a couple of our faculty, Dr. Sharma and Sahil Kera, are already there in person. So we are going to be showing
and we have a lot of other experts in the mitral field in India, and of course Raj, Praveen, Tose, and you'll hear a discussion with all of them.
Okay.
So we have got only half hour, 30 minutes, because we are running quite behind. So you have allotted 30 minutes as planned for your case.
Can we show the slides?
Can you hear us?
Yes,
we can hear you, but we are waiting for the slides.
The slides are a little bit delayed because they have to be transferred from where you are. So at the speed of sound.
Stuck in the cloud.
Yeah, stuck in the cloud, that's right. Everyone's ordering the new iPhone, so we got stuck on the cloud. But all kidding aside, thank you very much for the privilege to showcase an TEER device that, as you know, we have two devices approved in the United States, the Abbott MitraClip G5 and the Edwards Lifesciences Pascal. And there have been a lot of questions and discussion about, well, how do you determine which one to use in primary MR, because both devices are now commercially available for primary MR. And so hopefully this case will allow us to show you the features of the Pascal device. There's some distinct features, but also some similarities that, there is a learning curve with any new device, as we all know, whether it's TAVI or Mitral. But Dr. Kini now will show you the slides.
You are able to see the slides?
Yeah,
Yes.
Okay, so essentially it's a mitral regurgitation case where we have primary MR due to flail P2 and prolapse of the P3, which we will show. So these are the faculty which we have introduced, and we have cardiac anesthesiologist is Hanikman, Raphael Hanikman, who is on the anesthesia side. So this is a 83-year-old female who presented with exertional dyspnea, NYHA class 3. And of course, known moderate to severe mitral regurgitation, diagnosed about 2 years ago with Afib, and also has had severe pulmonary hypertension and other risk factors as you've shown there. So good medical therapy. Most of the time, you see that she has been on Lasix and continued to be on, continue to have symptoms. So regarding atrial fibrillation, I think she has had DCCV, but once you have mitral regurgitation and large LA, they remain in atrial fibrillation. So EF is 66, so primary mitral regurgitation, some MAC, and we are going to show you her PA pressures are above 60. So this is exactly what you can see, moderate to severe mitral regurgitation, and you will see the prolapse. And other thing is presence of the MAC is not going to help us so much when we are doing the clip. So severe mitral regurgitation, look at the ERO 0.68, and regurgitant volume also is very high. So we can show the you want to show the live echo?
Let's have Lucy show us live, just to make sure that no surprises before the live case based on the comparing to the baseline. So Lucy, take it away.
Hi, yes, thank you for having us. So here you can see this is live interprocedural echo here. She has baseline atrial fibrillation, and you could really appreciate the small size chamber of her left ventricle there, hyperdynamic EF in this view. Overall, the right function looks okay. She has a baseline minimal pericardial effusion just to begin. And here you can see that flail leaflet with ruptured chordae in the medial aspect of her valve, and again, that small overall thickened left ventricle. On echo color, you can see that eccentric anterior lateral directed jet of severe MR, just qualitatively here, but I'll show you quantitative measurements. And so on 3D, as Dr. Kinney mentioned, there is some posterior mitral annular calcification, but the primary etiology is prolapse with flail here. You can see very nicely P2 into P3, ruptured chordae and flail leaflet of the posterior leaflet. With color Doppler, very severe MR. It's progressed since her baseline, in my opinion. Using MPR, we're able to take a closer look at the leaflet anatomy and identify our target location. So we're going to target this location here, as you can see with the crosshairs on the bottom right. So right with the location of the flail leaflet. Using our measurements, her mitral valve area comes to 4.2 centimeters squared. The exact leaflet length at the target zone is about 11 millimeters for the posterior leaflet and 20 millimeters for the anterior leaflet, so appropriate leaflet lengths. Her vena contracta width estimate averages to about 0.7, consistent with severe MR. I did direct vena contracta area as best as I could with this jet. 0.63 is the direct planimetry of the VCA. In these eccentric jets, when they're anterior directed, you can try a PISA, but the best way to align your Doppler is transgastric. So this is a view here. You can see transgastric alignment. And then by PISA quantification actually is way more than baseline, 1.5 with a volume of 200. I did this twice. It's definitely severe MR here. She has flow reversal in her pulmonary veins as expected. And I'll stop there.
Yeah, so you see that, go back to the transeptal, so we were able to, all right, we did.
You want to slide? You want to finish the slides first?
Okay,
We'll finish the slide. So this is the summary of the case.
Yeah, so this is a summary. So 83-year-old, and of course we mentioned what we have to do. So our plan was to use Pascal ACE in this case. So I just want to show you a little bit difference in the device delivery system itself, which I think we will, Gilbert is going to show as we are proceeding with the case. But this is the key, right, Gilbert?
Yeah.
Why did we pick Pascal, and what is the difference? Why are we doing the ACE?
So there are two different, there's differences between the Pascal device and the MitraClip device. Number one, you can see that the Pascal here, the key difference, you can see there's a central spacer that is not there for the MitraClip. Number two, you can see those clasping paddles actually goes all the way to 180 degrees to clasp. So versus 120 only with the grippers, the MitraClip. So you can really adjust your grasping technique, and particularly in challenging anatomy like this flail segment. And then further to that, you can actually elongate this device to, you can see on the middle part, the figure, to completely like a straight device so that you can navigate more in terms of challenging anatomy and location. In this case, for example, that Lucy pointed out has small left ventricle, so you don't want to get caudal entanglement. Particularly, you can see that this was a more medial pathology, not a central pathology. So if you need to get yourself out of trouble, this, in our mind, is the ideal device.
Good. Other thing is, I know Lucy said the mitral valve area, today she's getting 4.0,
Yeah.
but I mean, our...
Yeah, and the baseline, we actually got less than 4. It was like 3.5. So that's the other thing that we found. Even though some of the current randomized trials did not show a gradient difference between the two devices, at least in our experience in more challenging anatomy such as MAC, small valve, very small female like this patient, we found that the gradient even after MR reduction really has not significantly increased. And remember, all literature has shown that in primary MR, after MTEER, you have to keep the gradient less than 5. And Raj actually had a paper that published from TPT registry that if you have gradient more than 5, it's bad for the patient. So I think this is very important for us in this case to assess the gradient afterwards.
Is there anything, the way this clip is made, we think will help in this case?
I think the fact that the gentle paddles, they're going 180 to class, I think it's going to be very important for this kind of large degree of primary MR pathology. And also because the mitral valve area is smaller, we know that it's going to be one device only. We're not going to put in multiple devices to reduce the MR, so there's a bit of trade-off. So in our mind, I think with this kind of situation, I think this would be more of a go-to device, because we don't have the shorter device that they have, that Abbott has, that would otherwise be potentially be an alternative in this case. But the trade-off that if a smaller device with the mitral clip, like if you use NT, you might not get as much MR reduction.
Dr. Sharma, you can ask the panelist.
Uses quite a bit, Raj, who has experience with both of them, mitral clip and Pascal at Sinai, that what is the working algorithm, which one to use when? So some guidance.
I think that when it comes to degenerative MR, I think both devices are good. In fact, the CLASP 2D registry and in difficult patients and CLASP 2D randomized clinical trials showed very similar efficacy and safety of these two devices. But I think what I'm attracted a lot is the ability to elongate and to bail. Okay, so you don't have, the occasional times when you get trapped in the cords. You don't have that. When you have a very short leaflet that is really tethered down, I think that you might have some advantage. That happens to be the case in functional MR. I think there maybe the mitral clip maybe a little bit better. When you want to use a smaller clip, like a clip and a half, then you can use a so you can have those combinations. Some would also actually, if the jet was wide here and you wanted to use one, some people would actually talk about using a P10. So you also have two lengths here, 6 millimeter and a 10 millimeter. And with P10, there's not as much tension and the gradient might be a little bit more forgiving. But I think we would start with exactly the way you are starting with the ACE.
Okay.
All right, great. Well, thanks, Raj. I think just in the interest of time, we still have quite a few steps to show the audience. Let's look at the transeptal. Lucy, you want to do it on echo? Can you show echo and fluoro and the device simultaneously, please? So free screens on the camera on the screen. Good.
Great.
Perfect. So go ahead, Lucy.
So this was the transeptal puncture we did just a moments ago. We had a height here of approximately 5 centimeters from the annulus. You can really appreciate, I know I didn't point this out earlier, that the left atrial dilatation is 6.5 centimeters in the medial lateral direction. So a severely dilated left atrium here.
Yeah, so you can see on fluoroscopy as well where we did the transeptal. You can see the MAC on the right side of the screen. We just realized this is the Safari wire to the left superior pulmonary vein, and you can see the guy coming in is very hydrophilic, very lubricious, very easily crossed. It's also a small profile. So after that, you remove the dilator and the wire, and here we are. So can we show the
Can we show the ceiling camera? The introduction of the clip is slightly different. So
can you magnify this?
Show the steps,
can you zoom in here, please, to show? So we already attached the syringe here. Yes. Yes, Sahel?
You need, Gilbert, a height of 5 here?
No, not really. We just, that's exactly right. So the Pascal is more forgiving in terms of transeptal height, but it was an easy transeptal, so we just went with it. We can always shed height if we need to, but you're absolutely correct. So just in the interest of time, can we show this and zoom in to see what we're doing here? So for those of you familiar with the Edwards Sapien system with the TAVI, this is exactly the same. You have a loader cap with the Pascal ACE device in here, and then we're going to insert in here. Just like we do that, okay? And then now we go in slightly. Once inside the body, you have to actually stop because remember, there's a column of blood here and you don't want air in there. So now we're going to open it and aspirate. First, we remove the
loader cap has to come out.
Yeah,
Yes.
and then we now go to actually, just like what you do with the TAVI system, we bring that back. We actually try to peel it off. There we go. Okay, and then now we go to aspirate. So the Edwards recommend around 45 cc. This is just so that you don't entrap air. So far so good.
More?
Yeah, this is probably the longest part of the procedure in our mind. You don't want to actively aspirate. So.
No, there is.
All right, almost there. All right, good. Okay.
But Raj, would you
Yeah.
use the mitral clip here?
Hmm.
You can use the mitral clip and you can use this.
Yeah.
I think both are equally good systems here.
Exactly.
In this case, while they are doing, the strategy will be to, because P2, P3 both are involved. So you start from medial to center or center to medial.
So you can see the device is coming out. So now we're going to put in the stabilizer. Can the people showing it here? Like this. Now you don't need to lock these two, okay? But you do need to make sure Bhavan was actually behind us, making sure there's one hand width. So you make sure that you don't end up accidentally exiting this, okay? So now we're gonna, yeah.
So Gilbert, your
Yeah.
clip is touching.
Yeah.
Maybe you want to put a little bit of flexion and turn it a little posterior, the guy.
That's right, exactly. So we're gonna do that. Yeah.
And watch your guide also.
Yeah.
Yeah, and you can pull back the clip.
Yeah, that's right.
So here, back here, this is where we close. Second catheter, push it forward.
See, yeah, I think you can pull back, not the guide, but the.
And you hear a click here. That's the key, okay?
Just make sure you have enough guide across the septum, Gilbert.
Yeah. Watch.
Yep.
You need to push the guide in and pull back the closer to the guide.
Yep.
So the fin, the middle catheter, that fin is sort of 2 o'clock.
All right, so the key is to try to get this in position for steering.
I'm gonna go to BICOM.
So just for the audience, you can see, right? So the fin here is at 2 o'clock and the device itself, the class is at 6 o'clock.
Retry, fluoro is gone.
Noon? Okay, and now we're at noon. Okay, so Dr. Kinney is going to now...
now look at the trajectory.
Down.
Are you happy with that?
Yeah,
No.
so we're going to come down, steering down now.
Yeah.
So you don't do that. So here. So this is the flex.
It's a very horizontal heart. I'll follow
Yeah.
you. Go.
Yeah.
So
Yeah.
Gilbert, you do have a lot of room in the LA. You can go a little posterior and then flex down.
Yeah, that's what we're going to do.
You're touching.
Go more peak.
We like,
Yeah.
when we do these
Why are we doing-
cases, we often steer in 3D.
Yeah,
And,
it's for interior.
You're good.
and you can see the MAC, you can actually see the MAC on fluoro, so that also becomes a little bit of a guide for you.
Yep, you cleared.
All right, we're on the valve.
Yep.
Yeah, but fluoroscopically it looks like you're very lateral, but
Yes.
let's go back and look at the echo.
Yep. You're anterior and lateral.
Yeah, see, all that would be very easy for you if you were looking at 3D.
I think that's a great point.
Yeah.
You want 3D?
They want 3D.
No problem.
No, do it the way you do it. But
Okay.
the thing is, I think you can. We don't want to. But that's
What do
very
you
helpful.
think about the trajectory here, Gilbert or AK?
Yes.
So I think we're a little medial. You can see that here.
Yes.
Yeah.
So
So we're now going more posterior, you can see.
Good.
Yeah.
But the trajectory is more of a, no? Fix it.
Here we go.
Then that was the catheter, or did you say? And so just
Where
All right, so let's get the BICOM explained and see where we are.
No, it's not like this.
So Lucy, what do you think?
Fix now.
So you are located, in terms of medial lateral, you're central, so that's
We're
good.
central, okay.
And then your trajectory on the opposite end is you're going to dive posteriorly this way.
Yep. So we now go more medial now.
Do you want 3D?
Yeah, so we're flexing the guide. So we're turning the knob to get a what called the equivalent of plus. And you can see actually go more medial, but also more posterior.
Yeah.
So we're going to go a little counterclock.
Yeah, you've come quite medially though.
That's right. Yes, exactly. And you can see the map there as well. So we now bring it back a little bit. And then we unflex a little bit because then we might be overflexed.
You're in the
based on-
valve. Yeah.
My concern is you may be overflexed here.
Yep.
Yes.
I would
So,
just flex off so it'll
yep.
tighten the system.
Yep, you can see we've done that already. Okay, so we're right on the mouth. So you want to do NPR, Lucy?
Yep.
To reconstruct that now? Mm-hmm. Pretty good, actually.
Our goal was what, 11:30, 5:30? I
That's
think
right.
we're just around there.
I think we should open. Okay, so I'll let you reconstruct that to tell us where. So the one key thing about NPR is that you want to reconstruct right to the anatomy, not where your device is. Your device may not be in the right place. So Lucy now is doing the reconstruction to show us. It's actually quite good. We're right on top of that pathology. We just have to make sure now the orientation is appropriate. So
Maybe just a titch lateral.
yeah.
Just not bad, but push the whole thing in.
Go lateral, you're saying? Yeah, a little bit lateral.
Too lateral, you're saying? Yeah.
No, a little bit lateral.
Yeah, we can go a little bit more medial here.
Go a little bit more. That's what I would think.
Yeah, so you
Yeah.
want to be on the medial side of A2P2 to grasp the entire.
We are, yeah. You can see Lucy's already pointed that out. That's kind of where we were aiming for. The red line you can see showing very nicely where we roughly are. So I'm going to open the device. Yeah. The fluoro. Mm-hmm.
Come a little anterior.
Yeah. Okay, so device is open, you can see. So let's see where our orientation looks like. It looks like we need to counterclock. So we need to be more counterclock. You see that here? So now you see the device coming into view in the red box.
Very nice.
So maybe we overdid it. We have to kind of go back. Okay, so we need to check the, I guess the grippers in terms of which is which. So Lucy, can you show us the red box in a bigger view so we can show the audience?
Yep.
So I'm going to undo the latch. So the dark gray is this, okay? So it's posterior,
Posterior.
everyone agree?
Posterior.
Okay, this is the light gray. All right, okay. And so what does everyone think about the orientation? Let's go back to the 3D just to check. In terms of, are we a little bit too clock now?
Yes.
I think so, Gilbert. This
Okay, so we,
moves a little bit more.
that's right, it's more.
But you may,
No, I go back to
How do
your.
you, Raj, what do you think? Or anyone else?
I think you are being thrown around.
Yeah, with the flail, right?
Flail.
Yeah.
Yeah, but I think you can go a tiny counter, but this doesn't look so bad. The thing is, what do you think about? You think you have a little? You want to stand up a little bit?
Okay.
But if you try to stand up, you might go below the valve. So you want to pull the device back a little bit. So
Yeah, this is as far back as we can here.
okay.
You can see that on fluoroscopy.
No, I don't like the way it is.
Yeah.
See that? Huh? Help for you? Okay.
Okay. Yeah. So you can see that here, Lucy showed you nicely in the green box that you have a lateral dive. For everyone appreciate that? So we're
Samir, you
gonna,
wanna come here? Come.
we're gonna flex a little bit more, so we can stand up a little more particular. Yeah. Yeah.
Flex your, because you have to stand up.
Yeah, that's right.
Gilbert, this is Samir.
Yeah.
So just turn guide posteriorly.
Yeah.
And then turn the first part anteriorly. Yeah, that one. Right, exactly. So keep doing that a little more.
Double twist.
Yeah,
Yeah. Here we go.
keep doing that. Yeah, excellent. Excellent. A little more. And then you can pull back everything a little bit because you went slightly.
Yeah.
No, no, now we are in the center.
And you see that, I think the audience, I hope the audience see that, right? And just to appreciate it. So,
You're a little bit more central now, though. You
yeah.
want to go more medial.
Okay, I think now we are better. You have to come medial now. You go
Yeah.
now more center,
Yeah.
Here.
And just the
posterior.
now just turn a little
Here.
bit anteriorly. Yeah,
That's it.
exactly. Yeah, beautiful, beautiful.
Come a little anterior. Yeah, that's good.
Yeah, we are.
Yeah,
There you go.
last part anterior. Yeah.
Yeah. Now, I think we're too medial now, no?
Yeah.
I think
Here.
we're
A
good.
little
It's-
bit medial, so just advance everything.
Yeah, that's what we did.
You see it on
Yeah, it's very, the flail is hitting us, as Raj has mentioned, so, but everyone is happy with this on orientation?
Yeah, I think it's.
I think looks pretty good, yeah.
Yes.
I think so.
I
Okay,
think,
so,
we are more posterior. Go a little
yeah,
anterior.
looking more posterior, yeah. No.
No?
Okay, so let's look at the red box, because that's our grasping view. That's the beauty about MPR here. So Dr. Kini is going to go advance the system now here. So nice thing about this device is that you don't need to close. With clip, we like to close because we don't want to get stuck. This device, I can see,
elongate it,
elongate.
So it doesn't kick around.
Right, so,
It's okay, that's fine, yeah.
Watch
You
the
did.
rotation.
I like closing and going in and then just go below and then open. And
right.
but here also you do have the leaflets.
So the leaflet's on already.
Yeah.
Yeah,
Yeah.
looks good.
So let's check the orientation again, because like you said, the system is not keyed. I think that's very important difference. So you need to actually make sure that orientation has not changed before we drop the class. I think looks pretty good there. What do you guys think?
Yeah.
I think we should do a little medial lateral sweep to make sure we're not missing any pathology. So Lucy, maybe you can, on the green box, you can show the audience, maybe just do a little bit,
I think you're okay, G.
right? So there's not
You have it all.
no pathology. Then laterally, do we have anything laterally? We just want to make sure that we're in the center of that pathology.
Yep. Yep. I'm sweeping on green. I'm looking at red. Everything looks good. Yep. I'm going to
Yes.
go back to red
But
big.
we all agree that you have the flail. I think you should grasp now.
Okay,
Okay.
all
No,
right.
but
We are
lift
going.
up, pull back a
Pull
little
back,
bit so
pull
that
back.
you have enough.
Pull
Yeah.
back. Yeah.
So Dr. Kinney is going to pull up now, and then I'm going to basically, we have to make sure that we haven't gone, medial, lateral.
Good.
Yeah. Yeah. So look at that map, right? You have to be careful about that map.
Looks very good on fluoro. The
Yeah.
orientation hasn't changed much.
Okay.
Lucy looks good.
Looks good.
Okay, we're going to drop now.
Drop both. Yeah.
Yep. Nice
Okay.
bounce on both.
There's a bounce.
So one thing really nice about Pascal, in our opinion, is that you can see these class bounds on fluoro and echo. Let's just show the audience. I want to magnify this actually to appreciate. Look at that. Can people appreciate it in the audience? I mean, obviously the panel experts can, but I think that's the main difference. Yeah, very well seen. Any comments? If everyone is happy, we're going to start closing.
Closer.
So this jump
So
which
this
we
is
see,
great
which is better,
imaging
it's
and-
better in this compared to MitraClip.
It's a very
Yeah.
user-friendly.
Yeah, so I'm going to start closing.
It's more stable.
Yeah,
And I feel that occasionally the procedure times may be a tiny bit shorter with the MitraClip. I think
Uh-huh.
this is this system is a lot more forgiving. It might take a little bit.
You want to give back a little bit?
yeah, we are.
We can. Yeah. Very good.
Do it
Beautiful.
slowly, nicely.
So close.
Yeah, that's Raj. That you have a great point there. For all our TEER procedure, we close very slowly, not just mitral but also tricuspid, because we don't want to, have tension in the system. We don't want to have any tearing. So I hear the click. Okay, so we are completely locked and with the class. So maybe now let's time to have Lucy tell us
Show
what to
some
do.
color. Yeah.
Yep. So
And we can
back
even
to-
connect to the left atrial pressure to see
very nice. Wow.
whether we can.
Wow. Look at that.
Yep. We got the complete flail. Looks gorgeous.
So
So-
in interest of time,
Yeah.
Dr. Kinney, Gilbert, we'll
Yes.
have to, yeah.
No, we'll show the release. We'll show the release.
Yeah, everyone agree to release or anyone
are-
want to move?
We have a few more minutes.
Lucy, let us know the gradient.
Oh,
Gradient now?
Just release the clip.
yes.
Yeah, I think so, right? Everyone agree?
Yes.
Yeah, I don't think we would chase after that a little bit lateral because remember we're still pulling on the device, and this is not an easy, friendly anatomy. I can tell you in the operating room, this will be pretty ugly looking. Okay, so we don't want to keep going back and forth, even though this is very atraumatic. And look at the
Okay.
gradient.
3.
Right, 3.
mean,
So
it's-
very acceptable, well less than 5 what Raj prescribed to us, in his paper. So I think it's very important to
Can you
make a
show
note
us,
of that. And the systolic
color
pressure
here?
is what now, anesthesia team?
Color on 2D?
Color on this one.
Yeah, 123 systolic, so it's
Yeah.
perfect in terms of hemodynamics. We see the hemodynamics. Can you show okay, you see the hemodynamics. So Alviva initially was 50. Okay, so you can see now it's cut by half. So
there is a, how do you grade that jet, which is a little bit away from there?
yeah, that's a little bit poor, I think, because of the, you can see it was a little bit deficient
It's
P1,
a-
P2.
Yeah, it's a narrow vena contracta, to be honest, and I feel like when we deploy this actually may get better. There wasn't much jet here before, although it could have been hidden because of the torrential MR on the other side.
Are you completely satisfied with the posterior? You think it's jumping a little bit more?
Yeah, there's a lip, but posterior is quite long. We can consider optimizing it. I think there's not a lot, we always see a lift after these primary MR, particularly the posterior leaflet's long. But we can certainly consider
What do you think?
to optimize here. So let me open here.
Yeah, I would optimize. You can see that jump there.
Yeah, let's see. You can see it's opening now. I'm going to bring it back. I'm going to go more posterior. Can we magnify the red box
Red
piece?
box, sure.
So the key here is to make sure you haven't rotated. Okay,
Remember,
this is a very,
Our posterior was 11, and it looks like we're going all the way up to the annulus.
yeah, so,
The anterior was 20
right, okay.
millimeters.
So let me just make sure I'm behind the thing I have to unlatch. So the dark gray was the posterior.
Yes.
So you can see it's all the way there, everybody. I'm not sure we can do more than that.
Yeah, yeah.
You agree? You guys agree? It's completely hung up there, actually.
Yeah, Moody would make us
I don't know if you're rotating now.
insist that we make that better. Now you actually, did we lose it or what?
You rotated now, yep.
I think it's just the way it's cut. We'll find out.
No, I think it is above it,
You think it's
the
above?
clip clocked. The clip is a
Mm.
little clocked, so that's why.
Okay, so I think
Here.
now it's.
Here, there you go.
This could be part of that cordy which.
Yeah, and now lift up.
There you go. Now I'm going to go back posterior. There you go.
Mhm.
Okay, everyone agree?
It's better, yep.
So I'm going to drop again, okay?
Yeah,
Here.
much better.
That looks
Better.
okay.
Yes. Okay, keep going.
One of the things I do less now is, you tend to, as you're closing, you tend to go deeper.
Yeah. You stop doing it, Lars?
Overdo that.
Yeah.
At times I feel that we overdo it. So
Mm-hmm.
we're a little bit tight.
I think it is tighter now.
Okay,
Okay,
it's
good.
clicked, so we are fully clasped.
Okay,
So
sure.
I think we are good. We can look at the color one more time, again, in the interest of
Wow, the jet is
time.
gone.
I think that is better. You're right. Show maybe the 3D in the big box, Lucy. Yeah, it looks
Yeah.
better, I think, in our mind, at least.
Yeah.
Now remember, initially, baseline, the P1, P2 is very deficient. So Raj, we're not surprised that there's a jet there. You see that? That's where the indentation is. So I think we just have to release and let it settle.
It's much
Because I don't
better
think
here.
I think just doing mucking around here is not going to be productive in
No,
my
the
opinion.
jet is much better after we optimize the posterior.
I agree.
Yeah.
You know, it pulled apart, you know, that indentation, and that's why we initially, that orientation is so important. So
Okay, let's release now.
yeah, so
You're
we're going
okay,
to release
right?
now. Everyone agree?
Lucy.
Yes,
Make
Dr.
sure you
Kinney.
lock
Okay.
it one more time.
Yeah,
Yeah.
lock
So I
it.
can make sure that.
Okay, do you hear the click? I heard the click. Everyone heard the click here. Okay, I'll do it one more. I don't want to break it. Okay, go.
Okay, release.
Yeah. The other thing is the release. It's so much easier when you release the
For the-
device.
Okay.
Okay.
The steps.
Can we show the
Yeah,
ceiling
please.
camera?
Okay.
Focus on the release.
Okay, we're gonna unscrew. Okay. So the posteriors, you have to make sure the color code. So this is the posterior, the bottom one.
Yeah.
You just pull.
Remove both of the things.
Yes.
Completely.
Okay, so we're gonna go posterior first, okay?
No drip.
And yeah, so you're removing posterior first so that if posterior comes out, you can still bail with this device. You can come out and
Okay.
And now we are going.
Now do interior.
Yeah.
Yeah, this is very, very ergonomic compared to the mitral clip system. Although the G5, for those who have experience, is pretty similar. There's no flossing the lock line and lever, just one knob, and you just take it out. So it's actually quite a nice improvement as well. So, but you do still have to check the final arm angle for the mitral clip, not unlike the Pascal system.
Good. Okay.
Here. Towards me. Okay, so you hear this little ratchet sound, and that's kind of deploying the device.
Yes, everyone hears it.
Slightly pull it, yeah.
Keep going. Maybe next gen they can do few of these. There you go. Very stable. You can see how much flex we actually had to
Yeah.
do.
Can
So-
you show the color again?
Yes, Dr. Kinney.
All right. That's
Look
it.
at that.
Okay, great job.
I think Dr. Adams would be proud of this result.
Okay. Gilbert says,
Thank you, everyone.
thank you, everybody. You can show our face now.
Thank you.
Thank you.
And
Show us
you
the full
did a great
camera.
job. The house is full. This
Thank
Friday
you.
evening, they still had 2 more
Thank you,
hours
guys.
of
Thank you.
lectures. But
Okay.
fantastic. Thank you very much.
excellent.
Thank you.
excellent job. Excellent.
Okay.